Good afternoon, everyone. Welcome to the Heart Health, Hearts and Minds Tools and Strategies to Prevent Cardiovascular Disease session. We'd like to pay respect to the traditional owners and custodians of the land, the Kaurna peoples, on which this gathering is taking place. We pay our respect to them and their culture and elders past, present and future. My name's Michelle Thompson. I'm the Nursing Policy and Curriculum Developer for Helios in Sydney. I'm also an endorsement assessor for APNA and reviewed the abstracts for this conference. So I would like to welcome you to the session and introduce you to our first speaker, Natasha Schranz. This session will go to about 2:15 and then we'll break for afternoon tea and then it'll continue until 4 o'clock after that. Okay, welcome to Natasha. Thank you.
Love it. Hi everyone. I love seeing a packed room of engaged people ready to learn. It's amazing. We are happy to stand and sit on the side, so if anyone wants to come up and use this table, please do. I just said that for you too, yeah. So please do come down and come to the front table so you can see all the resources. So as we just said, hearts and minds, tools and strategies to prevent cardiovascular disease. Now, I'm all for getting to know people around you, so for 2 minutes, well, no, I'm going to give you 1 minute. I want everyone to stand up, find someone at a table close to you that you have not spoken to yet, and quickly introduce yourself. Go for it. Second call. Ten seconds. 5, 4, 3, 2, 1. Good job, everyone. See, this can backfire. People can get way involved in their conversations. All right, we'll wrap them up and we can keep talking during break. That's good. No. So thank you, everyone. Hopefully you got to, again, this is what these types of events are about, meeting new people, finding different ways to collaborate and sharing ideas. So today's session, we want it to be pretty, informal is not the right word, but we want you to feel like you can stop us at any point, ask a question, get involved with the discussion, so we make sure you guys leave fully understanding what we've spoken about and feel involved with the conversation. Don't feel like you have to take a lot of detailed notes off the slides. There is a sign up, there is a form, you have lots of forms on your table. We'll refer to them throughout the session. There aren't enough for everyone to have one of everything, just before we get to fisticuffs. So there is one of the sign-up sheets with the Heart Foundation logo right at the top about this event. If you put your name and email number on that, we'll make sure the slides get it to you. I should have had a demonstration model. This one. And then just put it on the back and we'll make sure we email you the slides. So that'll have all the links and things to it. Now, any good workshop starts with who, what and why, so we know what we're here for, and if it's not what you thought, you can quietly walk and leave before it gets too far in. So the who, we're going to give a very brief 30-second bio of each of us. So my name is Natasha Schranz. I'm the Research and Translation Manager with the Heart Foundation here in South Australia. My background was in sports science through my undergrad honours and PhD, then with a focus specifically on kids and physical activity, and now a much broader look at heart health across the lifespan with the Heart Foundation. So that's me in a very small nutshell. Natalie?
Hi everyone, I'm the Cardiovascular Risk Reduction Manager at the Heart Foundation. I've newly joined 2 months in, so fresh. I've got a clinical pharmacy background and also some background in educating general practitioners with the NPS. So it's lovely to be here, thanks.
Yeah, I'm Jason. I'm a GP and an epidemiologist. I work mainly in rural and remote Australia, predominantly with Aboriginal and Torres Strait Islander communities, and I work at Gurni-Yillamukka, which is a community controlled health service up in Yarrabah. At the ANU, I do implementation research around how we improve absolute cardiovascular disease risk assessment in general practice. So that's why I'm here with that hat on today.
Excellent. I think we all got a sense of the types of people we have in the room here from your initial brief introductions to people you haven't known. And so moving on to the what of today. Now, here we've got what our focuses are going to be on. So we're each going to tic-tac with each other and speak to different parts. And the learning outcomes there are on the side. So first of all, Jason's going to focus on the epidemiology of heart disease. We're then going to move on to Empowering for Equity, the Heart Foundation Australian Heart Maps, which I'll talk to. Moving on from that, Natalie will come up and speak to us about heart age calculators specifically. After the breaks, after we come back from afternoon tea, I will be counting how many go out and how many come back in. Jason will speak to absolute cardiovascular risk assessment in practice and beyond. And then finally, speaking to reducing risk, patient support and resources. So that's where we're going to go to today. So hopefully that's what you signed up for. Now, the why, and probably that's the most important question in any sort of practice. Why are we doing this? Why should we be doing this? Those types of things. So for those of you feeling brave, yell out, could be one word, could be a sentence, why you chose to come here today to this workshop. What's the, to say hi to Jason. Excellent answer. Yes.
Cardiovascular disease is the leading cause of death in Australia.
Yep, excellent. Oh, I like it. We should have pitched that on our flyer. Like it. Yep. Anything else specifically?
Setting up a cardiovascular prevention clinic with cardiologists as well.
Excellent. Any more? I like this group. We're going to have some fun. So I'm hoping you all came for a variety of ranges, but we have a why as well, why we are so passionate about this area, why we all need to be passionate about this area, and that leads us straight into Jason.
Yeah, thanks, Sam. Thanks to Sarah, who's come just to see me. So I said at the start, mainly a GP, but I'm also an epidemiologist, which means that I have a disease where I really like graphs, okay? So there's going to be, in this first one, it's going to be a lot of graphs, sorry, I don't know which dialect I'm supposed to be using. And some people just get totally flustered by that, and I understand that. What I'm really trying to do is get a story. Hopefully that story will become really apparent as we get on. So don't get too flustered about what's on the Y and X axis and crap like that. It's really about the story about cardiovascular disease in Australia. So the first thing, does this work? This doesn't work. Cool, that's right. The first thing is that a miracle has really occurred in terms of cardiovascular disease prevention in Australia since the 70s. So this is looking back more than 100 years, back to 1907. And blue lines men and red lines females, and looking at the deaths due to cardiovascular disease. And you can see that in the first part of the last century it was rising steadily and then sort of plateaued off in the 60s, and then around the mid-70s we started getting this decline. That doesn't work either, we need a new battery. It's been really stark and really dramatic since the 70s. It's so much so that if we had those same death rates that were back then, an extra 200,000 people in Australia would die every year. Oh, it wasn't on. Winning. But 200,000, that's, literally 1% of the population would die from a heart attack or a stroke every year if there wasn't these massive changes that had occurred since the mid-70s. So for our little having a bit of a chat on the table to start off with, I want you guys to brainstorm what the hell happened over the past 50 years to contribute to this miracle. Okay, so have a little talk amongst yourselves and then we'll get answers back from the group. It was just not on. Don't worry. Yeah, it's fine. Thanks very much. Yep. Cool, we'll just wind it up. Sorry, you can probably go for a long time hypothesising why. Does someone from the table want to nominate some reasons why they thought that there was such fewer deaths now? Or smoking, excellent. Okay, so Australia was really at the forefront of introducing laws around plain packaging smoking most recently, but taxation and advertising laws. So our smoking amongst the general population is one of the lowest in the Western world. Yep. Other reasons? What's that? Education about what? About
the TV ads about heart health.
Oh yeah.
That kind of stuff that happens in schools, etc.
So sort of health promotion sort of work, I guess? Yep, great. So I didn't know this, but in the 60s, so I'm here with the Heart Foundation, they're not paying me or anything like that. There wasn't, they do a lot of stuff around health promotion, but one thing that they did was there didn't used to be a 000 number, okay? And they actually lobbied the Menzies government to get a 000 number so we could, anyway, so it's pretty amazing things that have progressed during that period. But yeah, health promotion is really important. Other things?
Advanced treatment.
Advanced treatment, so what do you mean by advanced treatment?
Or improvement in how cardiovascular disease are being treated.
Yeah, so what things specifically, you reckon?
For myocardial infarction.
Okay, so if we look in roundabout, so in the 70s, using aspirin a little bit, the late 70s, early 80s, started using streptokinase, and then now, we're starting to look into percutaneous intervention, okay? So, so acute treatment. What else? Coronary care units. Okay, we've obviously got a coronary care nurse. No. Look, and the whole model of a coronary care unit has then got adopted by the stroke units. We know that specialised care within a hospital makes a big difference, okay? And having those teams, that's what they're focused on, that's what they know, makes a big difference to the acute outcomes. Any other primary care interventions that might have occurred? Yep. Yeah, what drugs specifically? Because, which one? Statins, yep. So statins came in, so that made a big difference. Yep, and then we've got all our different antihypertensives, okay? Yeah, so more recently, we started to look at even tighter control within the antihypertensives, okay? Things like the Sprint trial. Yep, right at the back. Yeah, totally. So if you didn't want to hear, there's rising living conditions and wage. So we know that low socioeconomic status in of itself is a risk factor for cardiovascular disease. So it's one of those things where as we get more prosperous, the rate of cardiovascular disease has potential to come down. Any other things? Access to services? Yeah, okay. So there's a whole bunch more doctors around than there used to be back in the day, okay? And then there's a whole bunch more primary healthcare nurses than there used to be in the day, okay? So that access to primary healthcare is something that I think is really important, okay? And it's changed a lot. And we'll just go for one more because I'm reading the end of the table. Yep. Yep, people are more interested in their fitness, okay? One thing that I just got to put out there, just because one of my mentors is a guy that just hates saturated fats, okay? And he thinks that it's all about saturated fats, which nothing's all about anything, okay? But he's a big proponent that he'll always say that the death rate dropped before smoking rates dropped, okay? And he thought that was a change in the way we cooked our food. Great, okay, so amazing stuff has happened. And much more people are dying. Yet, if we look at the burden of disease in Australia, coronary heart disease remains the single cause of, single disease in terms of burden of disease in Australia. And that's because people die early from it, but then even if you survive it, if you've had a stroke in particular, and even with heart attacks, you have residual life-altering disability, so it actually impacts on your quality of life for many years to come. So the stat is about one person kills one person, cardiovascular disease kills one person every 12 minutes. And there's almost 4 million people living with long-term effects of cardiovascular disease. For Aboriginal and Torres Strait Islander people, the story is very similar, okay? We often focus on gaps, but if we look in the past 10 years, so this doesn't go back as far, this only goes back to 1999, and the top line's Aboriginal and Torres Strait Islander people, you can see a really dramatic drop in the rate of CVD mortality. The thing is, when we focus on the gap, non-Indigenous mortality has dropped at a similar rate, okay? So the gap remains, but really, when we look at the improvements to Aboriginal and Torres Strait Islander health in the past 20 years, improvements in cardiovascular disease mortality is the biggest standout by a really, really long way. But yet, it still contributes the most to the life expectancy gap. So big challenge. The thing in particular with Aboriginal and Torres Strait Islander people is that heart disease and strokes occur much earlier. Okay, so this is just showing CVD death rates per 100,000. We've got groups by ages, okay, going up from less than 24, where virtually no one dies of heart attack or stroke, up to 65 and over. And the dark red is in Aboriginal and Torres Strait Islander people, and the pink's non-Indigenous. And we can see deaths from cardiovascular disease start becoming prominent quite early, in 25 to 34-year-old age group. And the rate and it's always much higher than the non-Indigenous group across all ages. One thing that stands out for me is that the death rate between 25 and 34 is about what we see at 45 to 54 in non-Indigenous peoples, okay? Anyone got reasons why they think they might be having such a high death rate at a young age? It's a really complicated thing, but kidney disease is a massive thing, okay? So we have, and we'll get into that when we talk about absolute risk, but the overlap between cardiovascular disease and renal disease in Aboriginal and Torres Strait Islander people is really important. Yep. Diabetes, yep, similarly. Diabetes, really early onset, overlap with cardiovascular disease, 100%, yep. Rheumatic heart disease, yeah, it's a bit, so yeah, definitely in the remote northern Australia, okay, becomes less prevalent the further south we get, although there are some people in the southern states that do have it. Yeah, so that can contribute, but I think there's other risk factors that are much more prominent, but definitely is something that we see a lot. Yeah, that's good, okay, that's the cause of the causes, whoever said that, okay, totally, okay. That's the, if we're going to, I've got a great diagram that just goes all the way back to that. That's an excellent answer. Yeah, so that is the primary reason. But thinking about, so I'll give you 10 brownie points, but I can't really, I was looking for more specific modifiable things. I can't. We do try, I guess, in terms of what I do in my, I'm in a community-controlled health service, so my bosses are all Aboriginal and Torres Strait Islander people. I'm in a process of trying to decolonise primary healthcare, okay? So in some ways it can be reversible. Social determinants, yeah. So we talked about socioeconomic status being an independent risk factor, and unfortunately, large amount of Aboriginal and Torres Strait Islander people still live in very low socioeconomic status. Okay. Other things, big thing for me, from my group, so I work within an Aboriginal and Torres Strait Islander unit, and we've been really focused on smoking, and smoking remains at 42%. Prevalence amongst Aboriginal and Torres Strait Islander adults, so much higher than non-Indigenous, and it's even worse in remote Australia where it's above 50%. So the thing is we've made a huge amount of progress, but CVD remains really a massive cause of burden disease. But what remains there still is largely preventable, okay? And the way that we try and prevent it in primary healthcare is through predicting their risk of a heart attack or stroke in the next 5 years, because that's called absolute cardiovascular disease risk. And we're going to talk about it after the break in more detail, but really it's about thinking about multiple risk factors, these things we've been talking about: renal disease, diabetes, blood pressure, cholesterol, smoking, and putting them together to get sort of a prediction of what's going to happen in the next 5 years. It leads to better targeted pharmacotherapy, and it's more accurate than just treating on blood pressure and cholesterol. So when we look at the Australian population and look at where their risk is stratified to, so same sort of graph with the groups in the bottom and percent at had a heart attack or stroke in the dark red, high risk, medium risk and low risk. And you can see that, you know, as you'd expect, people with heart attacks and strokes go up as you age, and same with high risk, okay? And by the time we get to over 75 in the non-Indigenous population, you know, over 60% of the population has either had a heart attack or stroke already, or is at high risk of having one. What's probably more important is about the treatment. Okay, so this is looking at if someone is at high risk of cardiovascular disease, they should recommended to have cholesterol lowering and blood pressuring medication. Doesn't matter what their cholesterol blood pressure actually is. Okay, and we'll get to the reasons after the break. So if we look at who's on those medications, even for someone who's had a heart attack and stroke, less than 50% are on a blood pressure and cholesterol lowering medication. And if people at high risk, so greater than 15% of a heart attack or stroke in the next 5 years, less than 30% are on that recommended pharmacotherapy. So when we put it all together, we estimate that around 1 million Australians who are at high risk of cardiovascular disease aren't on the recommended pharmacotherapy, okay? And that's just looking at one component of treatment. We know that, you know, there's a whole bunch of dietary, exercise and smoking cessation interventions that we want to be supporting our patients to undertake. But if we just look at the tablets, 1 million people aren't on the recommended pharmacotherapy for them. For Aboriginal and Torres Strait Islander people, it's no surprise, because considering we saw the higher death rates, but this risk of cardiovascular disease occurs much earlier. So we use the same algorithm to predict risk, and when we use those same algorithms for Aboriginal and Torres Strait Islander people, we see that they're having high risk at around same levels of high risk about 20 years earlier. And if we look at sort of the real target for treatment, the sort of 45 to 75-year-old age group, 1 in 4 Aboriginal and Torres Strait Islander people are at high risk of having their first heart attack or stroke. This isn't taking into account who's already had one already. So it's an enormous problem, but largely it can be prevented. So I went a bit rushed because I thought we were taking way too long with all the responses. I could have taken a bit longer. But really the story that I was trying to get across for this first part is that we've had just an enormous improvement in cardiovascular disease over the past 50 years. It's astounding, you know. My boss, who works in public health, she always regrets that no one ever gives, you know, all the people that led to these changes a bottle of scotch to say thank you for me not having my heart attack or stroke this year, you know, because then we get like 200,000 bottles of scotch. That's not how things work. But despite the massive improvements in the non-Indigenous and in the Aboriginal and Torres Strait Islander population, it still remains, there's a huge burden of disease in Australia. As we've said, for Aboriginal and Torres Strait Islander people, that occurs early, and as come from you guys, it often occurs with diabetes and renal disease. And really, the real opportunity for prevention and things that we're talking about today is through there's population health interventions that make a big difference, but then in the primary care setting, there's, you know, assessment and treatment according to absolute cardiovascular disease risk. Now, I finished 2 minutes ahead of schedule. There's a lot of question? Yep.
This is semi-related.
Yeah.
I recently heard that the aspirin is no longer recommended for people with low risk factors.
Yep. Yeah. So there's been a couple of large studies that have looked into, or pooled studies that looked into the impact of aspirin for someone who hasn't had a heart attack or stroke, and the adverse reactions from the aspirin outweigh the benefits from aspirin. Okay, so for people that have had a heart attack or stroke, it still remains an essential part of their treatment. For people without it, it's not. It's primarily about hemorrhagic stroke was the problem for people on aspirin. The guidelines they just got funded to get revisited, and so within the Aboriginal and Torres Strait Islander health community, there's a sort of a thought that we see people at a much younger age and their risk of hemorrhagic stroke's lower. So I think that'll be revisited. But at the moment, the recommendation is unless someone's had a heart attack or stroke, aspirin's no longer recommended. Good question. Yeah.
Do you have much information on SCAD?
SCAD. I don't even know what SCAD stands for.
Southern coronary artery dissection in young.
Oh, no, it's not something that I look at a lot. Okay, sorry about that. Why you're interested in SCAD?
I've just got a friend who has
Oh, really?
a young fit mother.
Yeah. I think something to keep in mind is often there are these stories, about people who don't have traditional risk factors and then have a terrible event. And something that I'm very aware of is that these risk algorithms that we have, they predict risk, but they don't 100% accurate. We think they pick up around 75 to 80% of people that are at high risk. And there's always going to be people that don't get picked up and fall out. Yep. Yeah.
There is some information on the Heart Foundation website about SCAD.
Okay.
It still isn't completely comprehensive because there's still an enormous number of unanswered questions about it, but it might actually help people.
Cool. So on the Heart Foundation website. All right, so there's one other question over here, I thought, or scratching the hair. Sorry. Great. I'll hand over to Natasha.
Thanks, Jason. So now we're switching focus a little bit, and as Jason alluded to, I guess where you live can have just as much impact on your health as how you live. And so what I want to talk about now is empowering for equity and how important it is to understand that while heart disease does affect many across lots of geographic locations, there are specific places that we can deem hotspots, if you will, that are more affected because of these such things. And so I guess, and it's also important because we are quite knowledgeable, I guess, about our own local communities, more so than what's happening outside, which is very important. But sometimes it's also important to take a step back and look more broadly to firstly understand where there are deficiencies compared to your region, your area, compared to others, so that you maybe might be able to learn from others or see what are they doing differently. They're kind of similar in their population makeup, their sort of environments, those sort of things, but there might be some little things, some initiatives, some programs that they might be implementing that could work well in your environments, but also to see maybe where you might be leading in terms of, well, we're doing really well in this. It might be something that you can't change, but there might be something that's just, why is that a little bit different? And you might, if you investigate a little bit further, some of these modifiable risk factors might be more of a focus in one area to the other. So it's really important to take a step back sometimes out of our local communities and look at that broader picture. So what do we know when we talk about health equity? So some Australians, as we sort of alluded to, are at higher risk simply because of their social status, income, education, cultural background, or where they live. We know that health inequities are created by cultural, political and social systems that benefit some more than others. And then to create health equity, this depends on empowering communities, making sure that those within them feel empowered, feel included, and that everyone has the access to what they need for better health. So equity is about giving everyone what they need to be healthy, where equality is about treating everyone the same. So we need to remember that not everyone starts at the same baseline. So that graph that you showed, Jason, was really important, like really highlighted that not everyone starts from the same baseline. So some people might start from down here, some will start from here. So we can't give them the same treatment. Potentially we need to look at them as individuals and say, what exactly we'll get? What do we have to give you? What do we have to give you to get you to the same spot? Because it's not going to be the same. So that's really important. And so then it's really important to now, how do we highlight where these areas are or where we might need to have more of a focus, these hotspots? So that's where the Australian heart maps come into it from the Heart Foundation. Show of hands, how many people have opened the web link to the heart maps? Oh, okay. How many of you have actually used them for anything other than to just look? Excellent. So you'll all be ready to go by tomorrow. All right? That's my plan for today. So they are a national online platform that exposes different patterns of heart disease across Australia. So they identify these hotspots, if you will. So they highlight the association between socioeconomic disadvantage and remoteness and heart health outcomes at the state, regional and local level. And the heart maps themselves, so like Jason, I'm a bit of a data nerd. They are a collation of lots of national data sources collected during 2011 up to 2016. And they focus on heart health indicators such as hospital admissions, mortality, as well as health-related risk factors. Now, rather than just talk about it, I'm actually going to open it up and show you if technology works for us. So hold that thought. Yep. Boom. Excellent. Can everyone see that? I'm not going to make it large because then I lose some of my ability to navigate. Now, I'm going to talk to it by looking at my screen, if that's okay, just so the mouse doesn't become unruly. So here we have the main page with the Australian heart maps, and that's going to happen to me the whole time, but that's okay. So just to orientate you, these little bits and pieces up the top here, these drop-down menus, they're the things that you can select to focus in more about what you want to look at. So up top we can talk about geography. So you can look at state and territory, region or LGA. Across here, if you are at the state, you can look at all of them, or you can drop down to a specific state. You can select your indicator over here. So here, like we talked about, all heart health admissions, heart attack admissions, they break that down. Then we also have unstable angina admissions, heart failure, mortality, then all the lifestyle risk factors. So you can look at that, each of those separate to one another to see where the risk factors are. You can choose to look at male and female separately, age adjusted. Now, just always pick yes, but I feel like I should give a better explanation as to why. So we have different rooms of people that in these workshops today. Do you think the age distribution of everyone in this room would be the same as the age distribution of everyone in that room? So that's the same. Probably. Why? Shush. Okay, just shh. So across these different states, these different regions, the different local areas, that's not the case either. So behind the scenes, just be assured that there's been a data statistical method applied. So when you select yes to this, it means that's been kind of at a clean slate, so everyone's the same, so you can compare apples to apples. You can compare, they're ranking them relative to each other, so it's okay. Probably not the best explanation, but yes is good. It means everyone's on a level playing field to be able to look at each other as a comparison. So for this one here, and then show ranking. So this here is relating to these colours. So dark red is bad, lighter yellow is good, or better, not good. We won't use the word good, better. So here we're looking at all heart-related admissions, but I'm actually going to change this to mortality. We're going to keep it at all of Australia, and I'm not going to hang too long at this page. So over here, if you come along, you can look at the specific state and territory data. So Northern Territory is ranked 1 out of 8, so they have the worst mortality rates across the country. And that's when we look at age standardised rates. So that's when we compare them in terms of at that population level. So they're at 94.9 per 100,000 people. If we then go down to the better, come all the way down here, the ACT, they're 8 out of 8 because they have the better rate, and they're at 56.1 per 100,000 people for CHD mortality. You can then come up here and change them across to different indicators, and the colours will change. So we go, let's go high blood pressure. So you see how all the colours change. So Tasmania is doing the worst in terms of high blood pressure. And these are a little bit different. So the risk factors are per 100 persons. So we can say 26.5% of people have high blood pressure in Tasmania, and then so on and so forth down the list we go. Now, for those of you that are into data, like me, you can come down here, I forgot to mention it first, and look at the data sources and definitions. You know you want to. You know you go back home and you will. So that shows you all the different data sources that we've collated data from and the specific indicators that they've provided data for. It's great. And some other interesting things around how other people are using the heart maps too. So that's the very first kind of page of the heart maps. It gives you a very good overview. And if you wanted to drill down a bit further at this level, you could. So you could go by region. And there you go. So blank white means we don't have the data at that level. So we've only got data for the region for blood pressure for the ones highlighted. And then you can hover over each of the individual regions and work out what's going on. And then you can go down even further to local government areas. That looks pretty cool. So you can see that you can drill further and further down and compare at different levels and work out where everyone's sitting, I guess. Now, I'm going to end with local profile because that's what we're going to finish on. So I'm going to move across here to inequities. So again, over here, this is talking to that health equity stuff we just spoke about specifically. So you can select your indicator up top. So we're going to switch now. Who wants to, what do you want to see? What do you want? Smoking. All right, let's go. Do we want to look at both males and females? Yeah, we'll leave it at that. So this is differences by SES status. So you can see here that as the most disadvantaged, over here, their smoking rate goes up. That's probably not new news to anyone in the room, but it just sort of, this is the data behind it that shows us these statements that we can make, that SES is a risk factor in and upon itself, socioeconomic status, sorry. And then you can go by remoteness. So in terms of major cities versus inner regional versus outer regional remote. And again, the 22.4% of people smoking in rural and remote areas. And they don't have the level of data available for country of birth. So if we then went to mortality instead, difference in socioeconomic status, but now we also have the data at this level for differences by country of birth across the bottom. So you can see where that stands across there. So that's just a nice little way of looking at different indicators for heart health and hospital admissions, and finding that information you need to work out what are the specific things that are impacting on this beyond the way people are living. So in terms of, you know, it does matter in terms of the SES, it matters if they're rural or remote or in a metro area, and where they came from birth is a factor as well. So we need to be mindful of all of those things. And then building on some of the information Jason shared around Aboriginal and Torres Strait Islander people, so this speaks directly to Indigenous inequities. So this looks at Indigenous and non-Indigenous people. So here we're talking about rate difference. So we still have the same sort of numbers that we show. So this is hospital admissions. Do we want to pick something else? What else do we want to pick? They're your options. You don't have as many for this one. STEMI, that one. So that's where we sit. So those in the Northern Territory, 2.8 more times likely to be admitted for a STEMI into the hospital. If we then go down, and that 2.5 is that rate ratio down the bottom. If I try and hover over it, it's going to move for me. So that's right down the bottom. But it also shows the rate per 10,000 people versus the Indigenous and the non-Indigenous, and then it shows you the gap. So all of that is there. So you can play with all of that as well to really drill down, and then you can go even further again into region. So that there again drills it down even further, and you can be comparing across, and you can change the different bits and pieces. All right, so now I want to finish on the local profile because that's what you guys are going to workshop in a little minute on your own tables. So this is the local profile, which is really great. Again, local communities, seeing where we sit, and brings together all of that information that we were kind of looking at those individual pages. So here you can select your state or territory. Now, I've been pretty handy with myself. I got a bit of a list of people who might be in the room, and I've got about 4 or 5 of these examples on the table, and I did pick some of the local government areas that all of you come from. I'm sorry, I couldn't do everyone's, but there are some of you, so you might get one of your own on your table. But if someone wants to get, like, what state do we want? Victoria jumped in first. Let's go. All right. What LGA do we want? Whittlesea. That one? Yeah, they're all there. All right, so now I might switch to this one. So we can see here, so we've just picked Victoria, Whittlesea, and it's changed all of these bits and pieces. So here it's speaking to, so I'll show you down here. Down here is the legend, which shows you, down the bottom there shows you what each of the little symbols mean. And so here we're looking at, that's education level, proportion of Aboriginal and Torres Strait Islander people within that LGA, proportion of people aged over 65, dwellings without internet access, because that's 21st century problems, and proportion of people who do not speak English well enough. So if we go back up here, and this little population snapshot gives you a bit of a rundown of what's happening in the city of Whittlesea. So it tells you its population, it tells you its SES level, so it's quintile 4, relative with quintile 1 is the most disadvantaged, so that's relatively quite high. Disadvantage, then it goes, Indigenous status and low education attainment are all associated with higher risk of disease, along with the known risks of smoking, obesity, lack of physical exercise, high blood pressure and high cholesterol. So that's speaking to this part here. So that's the Australian prevalence, and then this is what's happening in Whittlesea there. So you can compare across to see if it's the same and what potentially might be deficient or not deficient, but what's lower and what might be having the biggest impact on health. Then over here, you can then play around with the specific indicator for that LGA. So we can look at admissions or mortality at this level. So some of them have more than others. So this one's admissions or mortality only. And then it will speak to the prevalence of risk factors down the bottom. So if we go to mortality, you see the Whittlesea percentage there, and if you hover over it, all the specific numbers come up for you. So that's 60.7 per 100,000 people, and then compared to Victoria, it's a little bit lower, and compared to Australia, it's quite a bit lower relative. Yeah, and that sort of tells that over here. It's significantly higher than the national average in terms of admissions. So they're at 56, whereas the national average is 48. And in terms of mortality rate, 60 compared to the national average of 68. So it's not a significant difference, but there is a difference. And then moving down to the bottom, in terms of heart disease risk factors. So here it's speaking to current smoking, high blood pressure, high cholesterol, insufficient exercise and obesity. That's the local, so that's the Whittlesea prevalence rates, and that's the national prevalence rates. So it tells you 32% cholesterol in Whittlesea is not significantly different from the national average, which is 33, has a prevalence of 24% for high blood pressure. It's pretty similar again to the national. Physical activity, 70%, which is significantly higher than the national average, so they're doing worse in Whittlesea compared to nationally. Smoking is 16%, not different to that of national, and obesity is 31% and is significantly higher than the national average. So that is a lot of information on that page in terms of their population makeup, what they kind of look like at a demographic level with regards to education, Indigenous status, those types of things, as well as then drilling down to specifically what we're looking at when we think of mortality and hospital admissions, but then drilling down even further into the modifiable risk factors and what they look like compared to the national. And while, we're saying here that it's in comparison to the national, are we okay with 33% of people having high cholesterol? Like, even though it's not different, you know what I mean? So even though that it's in comparison to the national, we need to actually look like at it just from the point of that there's 33% of people with high blood pressure or cholesterol. Which one it said? Cholesterol. So those are really important points. So I guess what I wanted to finish off with is for you guys at your tables to have a look at those handouts that I gave you. And the good thing is down the bottom here, you can just press on here and go download, and you can download a PDF and it will print that out exactly how it looks. So these are things that you can use to empower yourself within your community, within your practice, to be able to take away and make a case for why it is important to make these things a focus. We have a rate of inactivity of this, smoking or our cholesterol rates are really high compared to, the national in terms of hospital admissions. we're a lot higher as well. So making a case to see change happen. And it doesn't have to be huge change, but building that case and making people aware that there are these differences is really important. And that's one of the things that this little piece of paper can do. So I just want you guys just to sit at your tables, and I want you to pull apart that information and just maybe write down a few dot points about the key information that you would take from this document to sort of pitch forward why something might be important, and make it really tangible. So, you know, if physical activity, inactivity, is really high, this needs to be a focus which could be done this way. All right, go forth. So that was a very quick sort of snapshot of the heart maps, and hopefully for the majority of you who hadn't even looked at them before, you're now aware of what they look like, how they work, and the different types of, well, I use the word data, I know data can scare some people, but it is evidence-based data that you can use to empower your communities and broader to make some real clear decisions about maybe what needs to be focused on based upon those numbers. Remember, you can get these slides, so the website link will be on there for you. And my email was on before. I'm always happy to field questions about how specifically to use them. If you forget everything I've said, that's fine. I'm happy to talk people through it, because it is such a great resource that anyone can access and should be accessing. But now, I guess moving on, we've spoken about, I guess, in terms of how much heart disease impacts people across Australia, how we can identify specific hotspots and the importance of doing that. But I guess now, how do we motivate these people to make small steps, small changes to start improving their heart health? And that's where Natalie comes in to talk about heart age calculators. Thanks, Natalie.
Thanks, guys. All right, so I've got you for the next 20 minutes or so before we break, so it might be a little bit of a hard one to keep your attention, but I'll try my best. I'm a pretty loud person, so I won't let you fall asleep. And I don't think I need to dwell on why we're talking about risk, why we're talking about cardiovascular disease. Jason did a fantastic job at covering that this morning. But I just thought I'd remind everyone that, at the core of primary prevention of cardiovascular disease is the principle that CVD is largely preventable, with 90% of the modifiable risk factors accounting for risk of MI. So that's really the basis that we're coming from. We know that uptake of absolute risk assessment is not where it could be, and certainly Jason highlighted the under-treatment gap, this really big under-treatment gap of people at high risk in Australia. So there's room for us to improve. And today I'll, as Natasha alluded to, I'll be focusing more on people's perception of their risk and understanding of risk, and that's where we'll cue in the heart age calculator. But the evidence tells us that people tend to inaccurately estimate their risk, and in fact they sway towards optimism. So they think that they're okay. CVD is not relevant to me. It's for really old people in nursing homes, like these photos, and so particularly younger adults don't think about cardiovascular risk factors earlier on. And that's a problem, because by the time they're 50, 60 years old, they're already at high risk and we're throwing medicines at them. The other thing that we really know is that risk is poorly understood by patients. It requires a fairly, a reasonably high level of numerical processing to understand risk as a score. Your risk of having a heart attack or stroke is 15% in the next 5 years, but 85% I'm not going to have an event, so is that really that bad? So it takes a fairly high level of processing. So we know that they're fairly misunderstood by patients and even some clinicians. And we also understand that patients tend to have a dichotomous understanding of risk. I'm at risk or I'm not. It's not a continuum that gets worse and worse over time from their perspective. So that's something that we can certainly talk about in a moment. So what I'd love for you to do now is to pull out your phones, laptops, iPads, whatever you have, and move on to our Heart Foundation website. There you'll see in the middle of the landing page the heart age calculator. The heart age calculator was developed for people between 35 to 75 years old without existing cardiovascular disease. So if you fit that brief, you fit the eligible population for this calculator. If you're like me and you don't fit the age group, I just put 35 there and just like calculate it anyway and see what you get, just so that you can have fun. Oh, what? No. Okay, no. Anyway, so we'll do that in a couple of minutes. So, yeah, yell out when you're done. I wish I could get a photo. Everyone's so really intently looking at their phone. Oh yeah, Tasha, can you? Everyone's looking down to you. Yeah. We've got somebody celebrating over here. Yep, cool. How'd you go?
I'm younger than I am.
You're younger than you are. Cool. Good. Jason, how'd you go? You're younger than you are. Okay, I can hear some reactions. Okay, anyone want to share their reactions? How'd you feel? You got a higher age than your age? You didn't? Okay, yeah, but you're surprised by the outcome? Yeah? 5 years older? Yeah? 2 years younger? Okay, good. Any other reactions? 2 years younger? And that surprised you? Okay. Yeah. Just, be happy with the outcome. Okay, guys, we might come together again. I know you've had a few chats on the tables. Anyone want to yell out how they felt after doing that? Yeah? Oh, we'll get to those questions. Don't worry, there will be plenty of time to ask about questions about the calculator. Now I want to know what your emotional response was. Yeah? Yeah. Yeah. So that's, was that surprising to you? Did you, or kind of expected it?
Oh, no.
Yeah.
One had high blood pressure, the other one had low, so if I'm in between, there's no way if I'm fine.
Okay, cool. Anyone else? No? Okay, cool. So you can see that across the room there was a mixture of higher and lower heart age scores, and I can see that some of you were surprised, some of you were surprised about the positive or negative results, and some of you were perhaps expecting it a little bit with your knowledge of your own risk factors. And I kind of expected that. It's a room full of nurses, but I thought we could work through some of the background behind what a heart age actually is. And a heart age, or the heart age as a concept, has Been around for a little while overseas for some time now. And the Heart Foundation here in Australia are leading it here for the first time, so it's just coming over here now. Heart age is simply an assessment of cardiovascular disease risk factors and a comparison of those risk factors or assessment to a defined normal, healthy normal. And the best way that I could explain it relative to your current actual age is through this graph. So on the x-axis is your age over time, and then risk of CVD up on the y-axis. And so if your actual age is down here, we can use the pointer. If your actual age is down here, if we throw in all your risk factors to calculate your risk, and it comes up here, this is what a normal person at your age that should be their risk level. But you come up here, for example, then we equate that to your heart age, which is higher than your actual age. So that's how this works. The questions that you were asked as you pulled in, entered in stuff into your calculator are based on the Framingham equation, or the function, risk function, based on the huge Framingham heart study, which you'd be all very aware of. And we've estimated your risk in the next 5 years of a heart attack or stroke. Now, somebody pointed out earlier, where's physical inactivity? Very good point. There are a number of other risk factors that aren't incorporated into this heart age calculator, as they aren't in many other risk calculators. And that's just one of the things that we kind of have to live with. But physical inactivity is still a really important risk factor for CVD. But this is a motivational tool. It's not a clinical tool. So it's not a tool that we'll be using to treat people or manage their condition. It's a tool that we would like people to use in their first step to finding out more about cardiovascular risk factors, and in fact seeing someone like their doctor, their nurse, their pharmacist to talk more about their risk of heart disease. So that's where this stands. And it's all about comparing it to defined ideal risk. So in each of those categories that you filled in, there will be an ideal healthy range. And if you exceed that healthy range, if that's relevant, then you will you'll be arbitrarily assigned a higher risk. That's how it works. The heart age is not your risk of having a heart attack in the next 5 years or a stroke in the next 5 years. So that's not what it is. But it's to help you understand your relative risk according to your current actual age. And I'll show you an example of how that works in a moment. So the basis of the calculator is that if your heart age is higher than your actual age, it's suggestive of an elevated risk of heart disease, but it's not diagnostic of it. Nothing's really diagnostic with risk calculators, but in any case, it's a starting point. It's a talking point for patients to go away and see their health professionals. And there's been a couple developed internationally, which I'll show you in a minute. So again, what heart age is not, it's not a clinical tool. It's not something that we base our decision making around medicines on. And it doesn't incorporate all risk factors, as was rightly pointed out. And it certainly doesn't predict the age at which you'll have a heart attack or at which you'll die. And you laugh now, but there are UK calculators that do this. So our one does not do it or attempt to. And that's the NHS health check. These are just two of the most popular ones. There's dozens out there, all supported by either private or kind of non-for-profit organisations like us. And the New Zealand one down here came with a really nice display that helped people understand their risk as a continuum, and they were able to kind of play around with the dial and go up and down. And so that was a cool feature of that at the time. But the Heart Foundation has launched the first one, and there's certainly more iterations that we can do to get that moving. But the best way, I think, to show you the value of having a heart age calculator is to introduce you to this woman. She's a 45-year-old woman. She's a smoker. She doesn't have any diabetes or family history, but she's overweight and obese. Her BMI, I think I had put down, she's 93 kilos and 162 centimetres. So she's got risk factors for heart disease at 45 years old. But if I plugged all her values into the absolute cardiovascular disease risk calculator, she comes back at low risk. And so she's going to walk away and go, sweet, yeah. And that's really driven by her age at 45. Yeah, well, yeah, and sex, absolutely, yes. Given that women tend to have like a 5 to 10 year delay in risk. So she's going to walk away going, I'm at low risk, I don't need to change anything, I'm sweet for the next 5 years at least. But if she does her heart age calculator, she'll come back with a higher age than she actually is, at 52. And therefore, we're better able to communicate her longer term risk and the consequences of her current risk factors or her lifestyle choices, like in this case with smoking and the high BMI, and therefore motivate her to take that first step to do something about it, and perhaps even take ownership for that, so she can go forward now, not in 10 years when she's at high risk and her age has gone up and driven that risk value up. And yeah, risk in younger adults is a really topical issue at the moment, and it's something that we need to start looking at more and more with prevention of CVD. The heart age calculator helps people to kind of visualise that, to understand it in relation to their own chronological age. We know atherosclerosis is a slow but progressive event that happens in all of us. I think it starts at 15? Is that roughly? And so risk is a continuum, and we need to be able to communicate that with our patients. And yeah, being able to change these risk factors early on is going to help them in the long run, which I think we've covered. I thought I'd also point out that international guidelines are considering heart age as a valuable tool. So the British, the European and the Canadian guidelines have all recommended heart age in one way or another, suggesting that it's particularly useful for those younger patients where if we put all their values in, they're not going to come up as high risk, but it's a great motivational tool to get them to start thinking about their risk factors. The British guidelines go as far as to recommend medicines according to heart age, which I must say is a fairly extreme and was highly critically received by people over there, and it's definitely not something that we're doing here in Australia. I thought it would be a great idea to actually digest for you some of the evidence that sits behind heart age calculators, because there's been some work locally and internationally on these calculators. And I guess the first thing that I'd want to point out is that it's been shown to improve risk factors for cardiovascular disease. And that's when it was put on top of standard care, which was looking at the absolute risk cardiovascular disease calculators with your patients. So we have an indication that it could improve outcomes, which is really important, surrogate outcomes through blood pressure and cholesterol. The other thing, which was quite evident earlier on, is that it produces an emotional impact. There's better recall if somebody reacts emotionally to these calculators. And the cousin of the heart age calculator is the lung age calculator. And when they did this in people, particularly smokers, they found that even if people got a positive result, it still got them thinking about their risk factors and about, should I, kind of quit smoking? Should I move around more and that kind of thing? So, that's a really positive response for a calculator like this. It certainly helps enable shared decision making. It means that once we throw up those absolute risk values up on the screen, if our patients don't kind of react or go, that still seems like a really low value, you can pull out this additional tool to help people understand their risk a little better. And we also know that there's some evidence that it has triggered at least self-reported intent to go see a GP or to see a health professional about their full health assessment and risk assessment. So that's fantastic. And lastly, if it's the only thing that we achieve out of this heart age calculator, it prompts people to seek further information, and that's really all that we the very basis of what we want with all of this: finding out more information about their risk factors and what they can do about them. So I thought, that would be useful, just so that you know that it is founded on an evidence base. Here are some of the reactions, not from our calculator, but from a study that Crucibona did at the University of Sydney in 2014. And you could just see, my husband said I should do this as well, and I have to take action. I better get myself cracking, get my cholesterol down. And it's it's some of it's an emotional reaction, but certainly some of it is quite active and suggests people are going to go away and do something, which hopefully they will. And more just to let you know, the Heart Foundation launched this heart age calculator as part, a key call to action as part of our mass media and marketing campaign titled the Serial Killer Campaign, and that was launched in February. You might have come across it. It's all about increasing the relevance of cardiovascular disease to all Australians, and tackling that complacency that sits around it. That we've ticked the box, mortality rates are coming down, we've got it all under control, and really it's still, coronary heart disease is still the leading cause of death. So that was the intent, and it's interesting to see that since February 17th, I think it was, to wait till last week, we had over 260,000 people complete this heart age calculator. So you can see that the interest there, it's big, and we're just in the process of crunching that data a little bit to find out who's wanting to find out more about their risk, and what kind of demographics do we have. I've only got a small portion to show you today, but of the 20,000 people that provided us emails when they were completing these heart age calculators, we had 80% of them have a higher heart age than their actual age. Can't infer anything about their absolute CVD risk from that, but it gives us an indication that there's risk factors. Yeah, there's a question.
Do you have a target of what you would like to achieve in terms of number of people
that are doing this? Well, to be very honest, the target was very low when it launched. I think it was in the something like 25,000, and this smashed that target very quickly. So I've been told that, the team has a new target every week, and it just goes up and up and up. 250,000 was one of the targets 3 weeks ago, so we'll just keep setting it. Yeah, so I think we don't have a particular target around the percentage of the Australian population doing the heart age calculator, but there's certainly work being done with the Heart Foundation to work out what proportion of the Australian population do we need to push to get an absolute risk assessment, which Jason's going to tell you all about when he comes up. And that's a bit trickier because we need to figure out, the eligible population, figure out how many people are currently getting it, and that's probably the biggest issue, and then how many more need to get it. So that's in the works. Yeah, absolutely. It's a really good point, because setting national benchmarks and then communicating those targets to the rest of the country has been shown as being really beneficial for national prevention programs like this, like in New Zealand and the UK. Yeah. And one of the interesting things I wanted to point out was that something almost 30% and over 50% of people that did this didn't know their blood pressure or cholesterol values. And I'm sure many of you did the same today, just went, oh yeah, you can use the standard values. And so that's interesting in itself, and it means potentially there's some work that we could do to educate and support patients to better understand what their levels are, if that's appropriate. I won't dwell on this because Jason's going to cover it all, but I just thought I'd let you know, where does it fit in risk assessment? I see the heart age calculator as the first step to people understanding their risk, to finding out more about risk factors for CVD. And it certainly doesn't replace any of the other things that Jason will talk about during risk assessment, but it's there to support it, as we said. And I've put this up here. Please don't throw tomatoes at me. It's not. It's just a brainstorm. I thought it would be a good idea to figure out how can you, and you would be the experts on this, but how can you incorporate heart age calculators into your everyday practice? And one idea might be to throw a tablet. I say millennial. Throw a tablet in the waiting room, or put a poster up that says, here's the link to a heart age calculator. Do it while you're waiting for the doctor. Firstly, it makes people less grumpy because they're not waiting for as long, and also because they get to talk to their doctor about like a heart health check going forward. You know, and we can talk about this a bit later, the new MBS item. Jason will cover, will help support that, and so it's a good idea to start integrating it earlier on. You are, of course, involved in all of these steps, particularly the last kind of three, but you can also throw in the heart age calculator during a heart health check to help them understand their risk. So there's a lot of options here, and as I said, it's a motivational tool, but it can help support you and your patients, and all throughout the Heart Foundation, our website, our helpline is available to help support patients if they have any questions. So it's not all on you once you introduce it. I thought I'd leave like a couple minutes, 3 minutes, just for questions. Any questions about the calculator itself or implementation of the calculator? No, we're all good? No, everyone just, yeah, you can smell afternoon tea, can't you? Forget it. No, well, I hope you enjoyed that talk, and I'm always happy to answer any questions if there's anything you think of later. Thank you very much.
Just a quick recap of where we've been. So we started off with a bit of the epidemiology about CVD in Australia and how it's important to still have it at the forefront of our minds. We then moved on to empowering for equity and specifically focusing on the Heart Foundation heart maps and how we can use those at the community level and much broader to highlight specific hotspots within our communities, etc. And then Natalie finished us off with regards to heart age calculators and how they can be used as that first step or that motivational tool to get people to have those conversations that they sometimes forget about having and isn't at the forefront of their mind. So now moving on, we're going to speak directly to cardiovascular disease risk assessment, or absolute cardiovascular disease risk assessment, I should say, in practice and beyond. So welcome, Jason, again. Thank you.
Yeah, I like getting clapped every time I stand up. Anyway, just before I start, I am going to run off at 4. My wife's on call tomorrow and I've got a 3-year-old. And so I normally hang around for questions. So if there are questions and I'm pissed off out at the door at 4 o'clock because my flight's at 5:10, email me and I'm more than happy. Like, that's what I want to do. I want to talk to people through email if they've got questions and answer them if I can. So we're going to talk about absolute cardiovascular disease risk assessment. And it's really interesting. You know, we put in for this forum the end of last year, didn't we? Yeah, I think so. Yeah. And we didn't really time it that the week that we would come, there would be a new MBS item dedicated specifically to absolute cardiovascular disease risk assessment that practice nurses, you know, are going to play a really important role in providing. So sweet timing on us and sweet timing on you guys to be here. So we're going to cover that and a few of the questions around it because I've been answering a lot of questions for a lot of people about it. But first, to get to sort of the theory about what it is and why we think it's important. The first thing is to acknowledge that this is a new way of thinking for most people about risk factors. This epidemiologist that came around to the ANU last year did this talk, and it was called The Death of Diagnosis. And he's like, hypertension is not a thing, high cholesterol is not a thing, diabetes is not a thing, even heart disease is not a thing. Like, it's not a dichotomous yes or no, it's a continuum, and all these things are a continuum. And so, and we need to think about that when we think about person's risk. So for when I went through medical school, you know, I'm old enough that I could put my age in the heart age calculator. You know, it was, and I'm sure for a lot of people when you guys went through university and training, it was, if someone has high blood pressure, I treat their blood pressure. If they have high cholesterol, I treat their cholesterol. And now what we're going to be taking today is we don't do that. We put a lot of things in a calculator and then we treat blood pressure and cholesterol simultaneously. And the thing that really screws with people's minds is that we can do this, we often need to do this when someone's blood pressure and cholesterol are normal, okay? And that's a big shift in the way that we think about it. But to stick to the old way means that we're often over-treating people that don't need treatment. So my risk of a heart attack or stroke is very low. I run ultra marathons. I don't smoke. Yeah, that's my not so humble brag. Okay, and so my cholesterol can be, 7 if I wanted it to be, and really the benefit that's going to come to me from having a cholesterol lowering medication is minimal. Okay, and we'll get to the reasons behind that. So, absolute cardiovascular disease risk. We had this up before, but what it is the probability that you're going to have a CVD event, so normally a heart attack or stroke, in the next 5 years. And as I said, it's all multiple risk factors to come together, and it leads to better targeting of pharmacotherapy. So why care about absolute risks? Does anyone know this place? Balmoral. No, it's not Balmoral. Huh? WA, whereabouts specifically? It's Cottesloe Beach. Great. Correct. Okay. I grew up in the Shire, in ScoMo country, before ScoMo was there, and I grew up on the beach. I was a lifesaver. And then when I was at university, my family moved to WA. I'll get to the point. People are like, what is this? Anyway, and they moved. They didn't live in Cotters though, but this was the beach that we'd go to. And if anyone knows, Cottesloe is famous for a few things. What is one of the things? Is shark attacks. Okay, Cottesloe is famous for shark attacks, and it becomes really apparent when you get there because it's sort of like a reef this side, and there's a reef that side, and then there's a dog beach that side, and a dog beach that side, and then you just got this hub of people swimming here. And I'd go there in the morning, and everyone would be swimming up and down parallel to the beach, and no one would be swimming out to this buoy, although here today on that one there is. And so I was like, I grew up in the surf, I'm going to swim out to that buoy, it's fine. And I remember doing it, and I was just crapping my dacks, thinking, I'm going to get eaten by a shark. Like everyone's swimming parallel to the beach, because if you swim parallel to the beach, you're not going to get eaten by a shark. Anyway, and I did. I got out to the buoy, but it was really terrifying. And I was like, I went back and I was like, well, actually, was there an increased risk of me being eaten by a shark in WA? And Taronga Zoo keeps the stats of non-provoked shark attacks. If you provoke a shark, you sort of, you deserve it. And it is true. The rate of shark attacks in Western Australia, where Cottesloe Beach is higher than New South Wales. And if we look at the statistics, they end up being, it's about 40% higher in Western Australia than it is in New South Wales. Okay, so I was 40% more likely to do it. But if we actually look at the absolute numbers, and this is what absolute risk is about, my risk was 1.4 in a million in WA, and then the rate of shark attacks is 1.4 in a million in WA, and the rate in New South Wales is around 0.8. So by swimming, the actual absolute difference is 0.6 in a million more shark attacks in WA than anything else. So, and this sort of gets that question about whether it's worthwhile lowering my cholesterol. If my risk is already very low, sure, cholesterol statins are amazing and they do lower your risk of a heart attack and stroke, but if my risk was 1 in a million, it's higher than that, I'll give you a tip, but I've only reduced it by, it's probably not been great benefit to focus pharmacotherapy on me. Okay, and that's the essential thing that we're trying to think about with absolute cardiovascular risk. Who's going to get the greatest benefit from the treatment? So, this is a really busy slide. I was telling Nat before that I think this slide is awesome, and she didn't agree. What it's trying to show, so this comes from pooled data about cholesterol treatment. There's literally been hundreds of thousands of people involved in cholesterol trials, because a lot of people making a lot of money from it in the 80s and 90s. But the good thing about that is we have really great certainty around the impact of statin medication in particular. And we know that for every millimole that we reduce cholesterol, we have a 22% reduction in cardiovascular disease events. Okay? And that, in terms of efficacy of medication, that's pretty stunning. And the really interesting thing is that that decrease in risk reduction, risk reduction occurs regardless of what your cholesterol was. So if I went from 7.5 to 6.5, 22% risk reduction. If I went from 4.5 to 3.5, 22% risk reduction. Okay. And this is what it's trying to show. So this has got the amount of cholesterol that we've lowered, what someone's risk was of having a heart attack and stroke, and the amount of major vascular events that we've prevented. So if we look at the low-risk person, okay, if we treat, major events avoided per 1,000 people treated. So if I treat 1,000 people at low risk, I'm going to get, reduce their cholesterol by 1 millimole, I'm going to prevent 6 vascular events. That's still good, but we don't know that all medications have side effects, and so we want to target those medications and costs for the patient and for the government. So we want to target those for the people that need it most. Contrast that to someone who's got absolute risk of greater than 30% in the next 5 years, okay, is getting the same amount of risk cholesterol down, and we've prevented 60 events out of the 1,000 people that we've treated. The more that we can reduce cholesterol, and with diet interventions and with more intensive statin therapy, and that's why we're often advocating for quite intense statin therapy, we can get that down to 142 events avoided per 1,000 treated, which, there's little comparison in terms of the efficacy with other medications that we have for primary prevention. Someone had a hand up, I think? No? Okay, good. Stop me if this is going the wrong way. This is the same graph flipped around to make it confusing, but for blood pressure lowering. Okay, so similarly, there's been a huge amount of people involved in blood pressure lowering drugs, blood pressure lowering trials, and we see that it's not as profound an effect, but for every 5 milligrams of mercury reduction in systolic BP, we get around about a 17% lower risk of cardiovascular disease events. And same thing, doesn't matter what you were starting at, once you lower it by 5, it reduces it. And for me, I think that was a really great thing to realise, because we get so focused on targets. And I work with Aboriginal and Torres Strait people that are starting off a really high blood pressure often, in particular. And, you sort of get fixated on, I'm not getting down to 130 or 85 or something like that. But even if I've lowered it by 5 millimol of mercury, I've made a big impact on their risk of having a heart attack or stroke. And same thing with cholesterol. So it's sort of, for me, it's made me realise about, it isn't, as this doctor was saying, it's not a yes or no thing. It's about, we're lowering it and we're lowering their risk accordingly. Okay. Yeah, that's where the studies were based upon, okay? So the initial Framingham risk equation was based on systolic blood pressure. The diastolic does come into play in other risk calculators, but the one that we based it on and what these studies used was systolic. But you're right, there's benefits from diastolic blood pressure lowering. So the guidelines for absolute cardiovascular disease risk assessment are the same throughout all the guidelines in Australia. And they all go back to this book here, which is the National Vascular Disease Prevention Alliance, Absolute Cardiovascular Disease Risk Assessment. And what it does is we recommends that we do risk assessment on adults aged 45 to 74. They're the target age group because it's the greatest benefit. Just recently, in February last year, the RACGP, together with NACHA, so that's the National Aboriginal Community Controlled Health Organisation, released their guidelines for preventative health in Aboriginal and Torres Strait people specifically. And they're recommending, they differed a little bit from this guideline in that they're recommending that Aboriginal and Torres Strait people should have a risk assessment from the age of 30, okay? And, if we think back to the previous session and we're looking at the rates of death from heart attacks and stroke in 25 to 34-year-old Aboriginal people and where that risk was, it lines up with that, okay? And that's why it got lowered down to 30, because that evidence actually has come out since these guidelines were released. So there's sort of a pathway when we're calculating absolute cardiovascular disease risk in Australia. And the first thing is to determine whether they've got what we think of as clinically determined high-risk categories. And they're really important because, especially for Aboriginal and Torres Strait people, most people at high risk are at high risk because of these clinically determined high-risk categories. The most common one that you're going to see is diabetes and age 60, okay, greater than 60. If you're diabetic and you're over 60, doesn't matter if you smoke, doesn't matter what your cholesterol is, doesn't matter what your blood pressure is, you're at high risk of having a heart attack or stroke, and we recommend that you be on blood pressure and cholesterol lowering medication. Similarly, diabetes with microalbuminuria, so a raised ACR, they're at high risk automatically. People with moderate to severe CKD, so that's EGFR less than 45 is the main way to do it, or persistent proteinuria. If you've got a history of familial hypercholesterolemia, we know that you're already high risk. And then if you've got like really extreme levels of hypertension or hypercholesterolemia, so if your systolic blood pressure is greater than 180 and your diastolic blood pressure is greater than 110, automatically at high risk. And similarly, if your serum cholesterol is greater than the total cholesterol is greater than 7.5. The interesting thing about the 7.5 one was that in the Framingham study, like actually no one had greater than 7.5 cholesterol, so we just don't know what that actual risk was based on Framingham. So, and all Aboriginal and Torres Strait Islander adults aged over 74 are assumed to be at high risk. And you know, the stuff we showed at the start would confirm that. So if they have one of these conditions, don't bother putting their risk into the calculator. Just treat them based on them, and you don't need to do the risk calculator. If they don't, then we do the risk calculator, and in a second we'll get everyone to get out their phones again and look up cvdcheck.org.au. And then we categorise them into these three groups. So high, which is greater than 15% risk in the next 5 years, moderate risk 10 to 15, and low in Australia we classify as less than 10% risk in the next 5 years. I already went through it in that detail. But yeah, as I said, the team that I was in with ANU showed that more than 75% of Aboriginal and Torres Strait Islander people that are at high risk are identified due to clinically determined high risk categories. So for us that work in Aboriginal and Torres Strait Islander health, it's really focusing on diabetes and renal disease and the risk of the patient because of that. And this is a hammer this home one further time because I think it's really important, is that these are two Venn diagrams showing the overlap of cardiovascular disease in purple, diabetes in green, and CKD in blue, and different age groups for Aboriginal and Torres Strait Islander and non-Indigenous peoples. And you can see at all ages there's greater overlap for Aboriginal and Torres Strait Islander peoples. And by the time we get to the 65 years and over, you really don't see cardiovascular disease on its own. Like it only exists with either diabetes or renal disease, which is really contrast to the non-Indigenous population where a person's often just had a heart attack, doesn't have diabetes, doesn't have renal disease. So much so that more than 1 in 10 Aboriginal and Torres Strait Islander people with cardiovascular disease have both diabetes and renal disease, and whereas only 4% of the non-Indigenous population have, you know, we call it the deadly trifecta. One thing is to acknowledge before that it's not going to pick up everyone who's going to have a heart attack and stroke. When we look at it, normally these risk calculators pick up around 80% of people that are going to have a high risk of heart attack and stroke. And there's some populations where we know that it is underestimating their true risk of having a heart attack or stroke. So we know that it underestimates risk in Aboriginal and Torres Strait Islander people. So whatever the score is, in my head, it's like, well, it's probably a couple of percent higher. And that's the same for Maori, South Asian, Pacific Island, and Middle Eastern people, or people of background, sorry. Certain diagnoses underscore, so diabetes, depression, and people that have atrial fibrillation. So it's not accurate. It's you increase their score, whatever it is. People from low socioeconomic backgrounds, and if you've had a family history of cardiovascular disease before 55, all these things increase your risk higher than what is said in the absolute cardiovascular disease risk calculator. So we're going to do some stuff, having a crack at it. Go to cvdcheck.org.au, and on your table there's six cards. I didn't figure out how I was going to describe this. Anyway, you put one of each colour together and they make up two patients. Both patients should have high absolute risk if you match them correctly, okay? It's a bit of a puzzle. But you'll find, and I've deliberately done it so that you'll have a few tricks with using the calculator, okay? So just get out the CV risk calculator, and on your groups, try and make both those patients have high risk. So one of each colour, and makes up two patients. Yeah, one of each colour.
some of it might be you'll have to infer the HbA1c rate. So you'll have to match up one of each colour together. This is an example of science, but one of each colour. Say that's patient one, that's patient two. Both patients have to end up high risk. So
Sorry guys, I'll just for the interest of getting through everything, we'll just move on. So I'm glad my arts and crafts worked, okay? Because I was cutting up paper all day and writing out things and trying to figure out combinations. Anyway, so the trick with that was that everyone had a clinically determined high risk patient and another patient who was going to be high risk on the calculator. So let's just have a look. I think these two tables had familial hypercholesterolemia. Well, sorry, actually they had a super high cholesterol level of 9, I think. You guys had some end-stage renal disease, I think. Yep. So their eGFR would be less than 45. So from dialysis, their eGFR would be 5. Someone had a diabetes with microalbuminuria, and someone else had diabetes greater than 60, I think, or something like that. And the difficulty is if you had diabetes and microalbuminuria, the calculator wouldn't have alerted you that was high risk because there's no thing to enter albumin-creatinine ratio in the Australian CVD risk calculator. Similarly, for the patients that had eGFR less than 45, there's nothing for the calculator. So it's really important that you're aware of these clinically determined high-risk categories because they make up such a high proportion of high risk, okay? The other things that I did just to be a pain in the ass, some people were less than 45, so it was hard to enter ages. Some were over 74. What else did I was being a pain, okay? So sorry about that. But, like when you struggle with something, you engage with it a bit more. So that was it was mildly deliberate, okay? And I'm just a pain in the ass. The other thing was that most people had at least one patient where we think that it was underestimating their risk, okay? Either because of depression, because of low socioeconomic status, because of, I think someone was Middle Eastern, someone else was Maori, someone else Aboriginal Torres Strait Islander. So I think the really important thing to know is that some clinicians get really upset and feel like their clinical autonomy is being taken away from them by us recommending absolute cardiovascular disease risk assessment. And that's definitely not the case, you know, and it's definitely not the patient's autonomy is taken away at all. That's, you know, extremely important. Really, it's about, it is as accurate a guide we can have in Australia for what this person's risk is, and it's for you to make decisions based on that risk score, okay? And we have guidelines that we suggest you should be following. But still, you've got to take in all these other things when you're thinking about it. So for me, I'm often in my head saying that the risk is a little bit higher for my Aboriginal and Torres Strait Islander patients, especially considering I work in one of the poorest areas in Australia, and you know, if my patient's got depression, you know, so I take that what the actual risk score is, and I increase it a lot of the time. In terms of where else to do these calculators, so you know, hands up if you use best practice in your clinic. Good. Hands up if you use medical director. Oh, it's best practice taken over. Okay, cool. Hands up if you use your other. Okay, cool. That's about right. So anyway, so within medical director and best practice, and if you use Communicare, it's also within Communicare. There are inbuilt cardiovascular disease risk calculators that match the CVD check website that you just did. Okay, the benefit of these is that they can auto-populate if the patient data is in the right bit. Okay, so most people have age and sex in the right bit, but you know, you need to have the blood pressure in the blood pressure sections, and the pathology company needs to be sending their cholesterol and diabetes in an extractable format. And I won't go into, you know, what that is, but if that all happens, then really it just takes a click of a button. So, or 2 clicks or 3 clicks. So in best practice, you go to the clinical tab, cardiovascular disease risk, and it can auto-populates if it's been done there, and then it'll give you what your probability is. But yeah, it's, you know, practices are at different stages about entering data into the correct points, because it takes an extra couple of steps for everyone, and it can be difficult. My service is down the path where we already have to report on national key performance indicators to the Australian government, and one of them is about, you know, measurement of absolute cardiovascular disease risk. So we're quite good at making sure everything's in the right spot. Best practice, it's 1 click, okay? Oh no, medical director, sorry. I miss the days when I used to have medical director. Anyway, it's just the heart tab there, and it'll open up this window here, and if things have been put in the right spot, it'll auto-populate. This one, this patient is, where's his age gone? 67, is he? Okay, cool. I can't read medical director anymore. 67, so, and he's got diabetes. So this is recognising that as a clinically determined high risk category and saying he's already at high risk, don't need to enter everything else. Other tools, you know, there's the old paper charts, and definitely I think some patients and some clinicians still love these and love pointing to red and then moving down a few squares and being like, you can go to this green. I think it's a good communication tool, and it's whatever suits your style. Just because there's a computer app doesn't mean you need to use it. And definitely one of my mates who I work with, she works in a refugee clinic. She hates the computer, she loves the squares, and she loves the colours, and that's what she uses. Heart Foundation also supported sort of research project about enhancing the calculators, and it's led to this other calculator that's auscvdrisk.com.au. And so Chris Bonner did this with some people from University of Sydney and Bond, and this picks up all the clinically determined high risk categories. So it has a section for kidney disease. If they have diabetes, there is a drop down that comes for their ACR, and so it'll help alert you that they have high risk. And it's also got some different tools to help communicate. So if you're interested in looking at an Australian calculator that has a few different tools to help communicate, then I would encourage you to look up auscvdrisk.com.au. Treatment, we've already talked about for high risk, it's starting blood pressure and lipid lowering. I think the really important thing is it doesn't matter what a person's risk is, the greatest thing that they can do is to stop smoking. And that's, you know, so it's something to never forget. And it doesn't matter what anyone's risk is, advice regarding diet and physical activity is extremely important. For medium risk, the current guidelines are that, you know, you discuss it with the patient, but you're at a safe spot to sort of focus on lifestyle management for the next 6 months, and if there's no improvement, then it's encouraged that they start pharmacotherapy. And a little caveat is that if someone has persistent blood pressure above 160 and 100, we recommend they start on antihypertensive. So, the new MBS heart health assessment item, just fresh hot off the press on Monday. It's the item for vocationally registered GPs is 699. The other item number is 177. Cool. There's a few things to point out. So this is the item descriptor. It needs to go for 20 minutes. And it talks about most of the cardiovascular disease risk factors, so diabetes status, smoking status, cholesterol, and blood glucose, as well as blood pressure. And it involves not just doing assessment, but there needs to be implementing a management plan and providing them with preventative healthcare advice. So it's not just doing the risk assessment, it's about creating a management plan with them. It's targeted for those groups according to the guidelines, so Aboriginal and Torres Strait Islander people 30 years and above, and non-Indigenous or other Australians aged 45 years and above. And within the explanatory note says that risk must be calculated using the CVD risk calculator that we've been looking at today. There's been a bit of criticism about it, and you might hear it from your GP or whatever, and that's fair enough. What I think is really great about it is that it provides, I work in a clinic where my practice nurses are heavily involved in our care. We have 6 doctors, 6 practice nurses, 2 midwives, and a team of about 20 Aboriginal health workers. So I want items that they can do on themselves, because I want them to operate in the full scope of their practice. And for them to be remunerated for it. It's me and my mate who's the midwife, it's even crazy the level of remuneration she can get compared to a nurse practitioner. But anyway, this is a whole side story. But this is an item that practice nurses can do the vast majority of. So it sits within all the health assessment group items, so group A14 if you're an MBS nerd. And so that means that practice nurses can do most of it, and that includes not only information collection, but also advice regarding the recommended interventions. So I think if this health assessment is going to be taken up and be used to drive increased uptake in risk assessment and management, it will be through practice nurses. Because this is previously health assessment items were really restricted to 45 to 49 and 75 years over. This is available for everyone every year from 45 and over now. So that's a really unique thing. And it's, at the moment pays at the same as level C. Soon it'll pay, I've been told that it'll pay up to the 100% level, 100% of the fee, which is $85. So, in terms of viability of the practice and keeping practice nurses within the primary healthcare team, I think it's going to be an important tool and also important for increasing absolute cardiovascular disease risk assessment. Any questions about the MBS item? Yep. Yeah, that's that's 100% right. Okay. I heard, so one funny thing though is that it's unidirectional, okay? So if you've had a 715 in the last year, you can't claim this. But if you haven't had a 715 in the last year, you can claim this and then you can claim a 715, okay? And that comes from a reliable source. So it's a disappointing thing, and it adversely affects Aboriginal and Torres Strait Islander patients because, for non-Indigenous, we didn't have access to a health assessment item for the vast majority of them. But for Aboriginal and Torres Strait Islander people, focus on the 715. And, whether you're going to do that tricky thing, it's fragmenting care and it's a bit, it's not best practice. Yep.
Do you know, so the 45 to 49-year-old?
Yep.
Was that claimable?
Yeah, no. So they're not co-claimable. That's what we're trying to do. So it's the same thing as 715. So any health assessment item can't be claimed within a year of that. But as I said, you can technically claim it and then claim something else the next day. Yep. No. So it is co-claimable with. So the language within the legislation says that it's co-claimable with other items outside of health assessment items if clinically necessary. Okay, so practices differ in their interpretation of that. I know a number of practices don't do health assessment items with GP management plans and team care arrangements, and others do, and so just always check what your practice does. But the legislation that it came under said that if it is clinically necessary, you can bill other items. Any questions? Cool. Am I still going, or do I? No. Oh, you're going?
I'm going to give you a quick break.
Cool.
Not very long though, so don't go far. So we're not going to give Jason long to sit down and rest, but we thought we'd better give him just a tag team out for a minute. So now I guess we're coming a bit full circle. So we've spoken about the importance of focusing in on cardiovascular disease, empowering for equity, how do we motivate, then how do we assess risk. But then once we've done all that, we need to be doing something to reduce their risks. And Jason touched on that as well. But I think we need to think about other supports and things that we can be giving to our patients and to you as health professionals to use within your practice. So I'm just going to very briefly touch on a couple of the very tangible, can reach out and grab them right now, resources or supports from the Heart Foundation. And that is the first one, the Heart Foundation helpline. How many of you were aware of this before you came in today? Good. Have any of you accessed it professionally for extra information? Excellent. So this is something that you can recommend to your patients. Hopefully you can get in touch with us to get some of our flyers. We'll have some up at our exhibition booth as well, so please come visit us and grab some. It's really important that they know that this is a number that they can call, their family members can call, other health professionals can call, just to reach out and grab some more information. They're willing and able to chat to them and chat them through and to point them in the right direction of where they need to be going and to what they're asking. So make sure we get that number out there because it's something that they can reach if they want to. And then before I get Jason back up as well, I just wanted to flag the Heart Foundation walking groups. So this is something yourselves can get involved with as well, be champions in your communities, in your practices. You could start up your own practice walking group, which is, we've heard of those being really quite successful in creating a sense of community, etc. So I'm not going to go through the numbers, but as you're reading them, you can see it kind of speaks to itself about its success and in terms of creating a sense of community while getting people more walking and more active. And we do know that's one of the simplest things we can do just to start people making positive lifestyle choices. And so all you need to do is go onto the website down the bottom and find out more information about how to get started. So is that really tangible thing that you can do for yourselves, your patients and your practice? But sorry, Jason, you're back up again. So now we're going to move into motivational interviewing and techniques around that. So you're going to get another clap.
Cool. Yeah, so with my group that I work with at ANU, the more we look into cardiovascular disease medicines, the more we realise people aren't taking them when they have lots of good reasons to be taking them. And so, I think there's, we just sort of this misguided belief that, someone has a heart attack or stroke, they get told take these medicines and then they miraculously just continue to take them for the rest of their lives, And the reality is people come in and out of taking their medications or need to stop it because of interactions, a whole bunch of stuff. And so whilst motivational interviewing is a technique that we've traditionally focused on with drug and alcohol addiction and smoking cessation, I think it's got a lot of relevance for medication adherence, and research would suggest that it does help improve it if you use it as a technique. And I'm sure many of you guys are already doing it, so there's no way you can give justice to the complexities of motivational interviewing in 30 minutes. What we can do is share some of our own experiences. One of the cool things about a conference is that you've got a whole bunch of people from different practices and you can talk to one another. So today, hoping that you can learn from each other's experiences. And there's presentations that I do. I work with an Aboriginal nurse, Vicky Wade, who used to be at the Heart Foundation. Now she works at Rheumatic Heart Disease Australia. And, she helped create a case scenario around specific considerations when working with Aboriginal and Torres Strait Islander patients. She unfortunately couldn't be here because Rheumatic Heart Disease is having a workshop in Sydney today, I think. So the first thing is that prescribing does not equal treatment. So the first study that my group did was just looking at how many patients said they had been prescribed, or not, they showed what medications they had and whether they had what was recommended according to their risk. So we showed this earlier, but for people that have had existing previous heart attack or stroke, just under 50% are taking both blood pressure and cholesterol lowering, and around about 20% are taking neither. For people at high risk, only 30% are on both blood pressure and cholesterol lowering. Something we've been doing recently is we've been seeing people who have been discharged from hospital following their heart attack or stroke, and then seeing how much they're filling in their PBS scripts, just using administrative data. It's big data, nerdy stuff. And what we find is that for people so a lot of people don't even start, so a lot of people don't get their script within 2 months of being discharged from hospital. But for the people that did start their medication, only 40 to 60% are still taking that medication regularly within the first year of being discharged. And when we say regularly, we mean they're taking it 80% of the time, so 4 days out of 5. And these are the people who, they literally just had a heart attack and stroke. And they're not doing it. So I guess just to start off for this session, on your tables, I think everyone knows some reasons why people don't take their medications. I just want you guys to talk amongst each other about why people who have had a heart attack and stroke might not be taking their medicines. All right, we'll just come back. Does anyone want to just throw out some reasons why patients, don't do what we tell them to, Don't just take your medicines like we said. So any reasons why people aren't doing that? What's that? Affordability, totally, okay. So I don't even know how to spell affordability, God. Cost, oh man. Cost, okay. It's really interestingly, we looked at who's taking their medications based on socioeconomic status, and it's one of the few things where the lower socioeconomic status are more likely to be taking the medications, okay? And it's because they're paying $7.60, I think is that what's the gap now these days for healthcare card holders? About $7.60. Whereas, if someone who's not is paying over $30. And then if you think, following a MI, you're going to be prescribed at least on, antiplatelet, so aspirin, ACE inhibitor, beta blocker, cholesterol lowering medication, and you've got to wait till you spend $1,200 in a year before you get onto the safety net. So cost is a big barrier, and definitely it's a big consideration for lots of people. Yeah, other reasons? Side effects, yeah. Side effects is a big thing. Nat was involved with, back in her old job, was around statin side effects, because a lot of people report the muscle soreness, and that doesn't mean that it's a lifelong never have it. It means that there is a specific approach to trying to get them on a dose of a statin because we know that there is a benefit for them, okay? But definitely people have experienced side effects from statins, from antihypertensives, and that can stop them taking medicines. Other reasons? Yeah, definitely, okay? That's a real big challenge with any preventative treatment, isn't it? Is that people don't feel unwell. So there's often a lot of people, when we look at that sort of taking it 80% of the time, a lot of people are like, oh, I've got a headache today, I'll take my antihypertensive, you know what I mean? And it's sort of treating it on a based on symptoms rather than thinking it's preventative medicine. And, in terms of how we've approached medicine, this whole starting treatment and going on for life is a really new thing, only in the last 50 years. So it's not surprising that people still struggle with that idea that you take things even when you feel well. Yeah, other reasons?
We talk about the poor understanding.
Yeah, poor understanding. Yeah, I think they're linked, isn't it, with the feeling unwell, but you're right. So one of the most important consultations, I think, for any patient following their heart attack or stroke is the first time they get to their GP, or to their primary healthcare centre, because either the practice nurse or the GP often spends a lot of time explaining what the hell all these medicines that they've just been started on are and what the benefit is. It's a long consult for me because I go through and sort of talk about it because they've often, it's been a massive event, but, now you can get discharged following an MI within 48 hours. And so you sort of have your MI, have a whole bunch of stuff and pop out on the street with 5 medicines. And it's really disorientating and hard to understand why you're on it and and also that whole concept that you are going to be on this for life. I think some people feel like they've done something wrong because they're on something for life. Okay. Yeah, being punished. Yeah. Okay.
But some of the younger people who are obviously at a high risk, they're playing with risks their whole life.
Yeah.
And it's not understanding the risk. Is that how you're
Yeah, definitely. Okay, so we were talking before that this whole concept of risk is really difficult as well, isn't it? And so a lot of people would just be like, yeah, I'll just give it a chance. I'll just take a chance. Won't wear a seatbelt, won't wear a helmet, won't take my antihypertensive and statin. Other reason? Transport. Yeah. So yeah, that's sort of linked with cost as well, isn't it? Yeah, for my clinic, we do a lot to try and address this, and we have a certain group of patients that we know aren't going to be able to get there, and so we provide them with a Webster pack and deliver it to them every week. So you're saying depression? Yeah, so I think any type of mental illness, isn't it, really, can really impact on whether you want to take the medicine. And we know that following a heart attack, that there's a higher prevalence of depression, okay? Any others? Yep.
You don't like taking medicines or you haven't really taken them before, it's like having a whole new habit to have to start.
Yeah, yep.
As we know, having to start a new habit like exercise is not easy.
Yeah, definitely. Not to dob my wife in, but
I'm going to do it anyway.
she's not going to watch the video. But she has to take Clexane when she's pregnant, and she hates it, and two, she forgets all the time. Anyway, she's not meeting 80%, and it's just a forgetfulness thing. She 100% realises the importance, but it's a habit that happens for a very brief period of her life. And so establishing new habits and doing those things we talk about with linking it with brushing your teeth, I think if you brush your teeth regularly, is an important thing to do. Other reasons? Yep.
People might change lifestyles in a positive way and then think, well, I don't need.
Definitely. So that just people couldn't hear this. So people change lifestyles in a positive way and don't feel like they need it. Okay. And so I think they're probably the most interesting group, actually. There's my boss. She was talking to me about the person that has the lowest cholesterol in her clinic, and it is a person that's at clinically determined high risk, but they're just so diligent about their diet and about healthy fats and avoiding other fats that their cholesterol is just super low. And, and she doesn't prescribe a statin for it, because they've made that change. And that's the really difficult thing. You want to encourage, there's this tension where we really want to encourage people to change their lifestyle habits because they have benefits just outside of only their cholesterol level. It has multiple benefits from diet and exercise. But at the same time, we still want them to keep taking this medicine. And often, I think our brains like thinking about either or. I'm going to do it without medicines and think I'm going to eat healthily and take my statin is a challenge cognitively. Other things? Access. So what do you mean by access?
Is the tablets available in that community?
Yeah, that's true. Okay, so for people who live in rural and remote areas, access is a big issue. You'd hope with a statin or the antihypertensive that wouldn't be, but at the moment, we're going through a shortage of the main antibiotic that I use in my community. It's obscene, so I can't actually give them best therapy because my community doesn't have this specific antibiotic. So access can be a really big problem. I filled up a page, which is great. The other thing, Struth, I'm going heaps over time. I've got to go explain. The other thing I always like to think about is, and we sort of captured a little bit, but it's just polypharmacy, and it just becomes really difficult to manage all these multiple medications. And like those issues around side effects become even more pronounced when you're on multiple medications. And we know that our patients aren't just taking one. What am I going to do with, okay, it was good answers. So motivational interviewing, for people that aren't familiar with it, there's really three main things. Person needs to want to change, they need to feel they can change, and they need to feel now is the right time to prioritise action. And so you can see that a little bit about what we've been doing today with using the heart age calculator in particular is increasing that desire to change within patients, okay? So that they sort of think there's something real happening here. The next thing is about feeling they can change. And, you know, it is, we just sort of think, I'll just take these tablets, but there's often other barriers going through that are confronting them to them taking that tablet. And that now is the right time. And, you know, within, Vicky and I, when we sort of talk about people taking medicine within community, it's often is about that when is the right time to prioritise action. You know, for a lot of elderly people that we work with, they've got multiple competing priorities. They're not just a person with high risk of cardiovascular disease. They're often, you know, a leader in their community. They're often looking after multiple family members. And they might not have a lot of money at the time. So making it so that now is the right time can be really difficult, and negotiating that with the patient is really important. I think one thing that is with motivational interviewing is, and this is the good thing about it, is about acknowledging that the patient's the expert and that they're going to find the best way to change. You know, you're there to facilitate and collaborate with the patient and respect their autonomy, not this shake fingers and tell them they're doing wrong for not taking their medicines. One other thing that I think is really important that doesn't really get put across is that that person's high risk is going to persist for a really long time if they don't have a heart attack and stroke. So and the great thing about primary healthcare, and the thing that probably a lot of people love about it, is that you see these people for a long time. And so while you might not make a change today, something you might say might have an impact on them later. The best example I have was a patient who had type 1 diabetes, and he hadn't seen a doctor for 2 years. He was staying alive by taking his son's insulin. And yeah, anyway, but I'd been coming to the clinic for a year, and his wife worked with me, and she figured I was all right, and so she brought him in. And, you know, he's high risk, he has diabetes and renal disease. But for the first couple of consults, I didn't change anything. I gave him the script for the insulin he was using, you know, and took some blood tests, came, we talked about him, you know, and talked about things. And it took about a year to get his insulin control proper. And we'd raise this stuff around his high risk of cardiovascular disease. But he didn't want to take the other tablets, and we just raised it but left it. And at some stage he started smoking again, and we got him back off that eventually. But then it took about 4 years, and then he switched one day, and he's like, oh, you know, I want to start those medicines. And so the great thing about primary healthcare is that you know these guys, you get to talk to people for a long time, and you can have multiple opportunities to instigate change. One of the things they talk about with motivational interviewing is strengthening commitment to change. So it's sort of like talking about what's good about doing what you're doing now, what's the disadvantage of staying the same, then talk about what's difficult in changing, but what are the benefits. And then the final thing is about creating a change plan. So I think within this new MBS item, the idea is not just to be like, you know, you've got high risk of, high absolute CVD risk, have a statin and a ACE inhibitor and go on your way. It's to set goals with the patients that are meaningful for them. And if it is that patient doesn't want to take medication, even though you've spoken to them about their risk and they want to focus on lifestyle, I personally think that that's the thing to do, is to focus on what they want to, but encourage them to take those medicines when they're ready. Looking for what supports is extremely important. And we've talked about other services that they could access. But the whole way through it, it's about ensuring that the patient's driving the change. So we'll just do this case study for last thing before we finish up. So Roy is a 55-year-old, and he comes to the flu vax and his pertussis vaccine. He says, my daughter made me come. She's about to have a grandchild and she won't see me till I have had whooping cough vaccine. This is a real story about my dad. But my dad's the fittest man I know. So this man used to smoke, but he restarted 15 years ago due to stress. He's tried to quit cold turkey, but it hasn't really worked. He travels a lot, and because of that, he eats a bit of takeaway and doesn't really feel like he has time for exercise. So when we look at this man, his BMI is 31, his blood pressure is 150 on 100, his cholesterol is 6.5, and there's his stats. Has anyone got a calculator out and just quickly calculate his absolute CV risk? Anyway, I know what it is, but I've made this scenario up. And he's one of those guys that's sort of like, the numbers don't really mean much to him, you know, sort of like, I guess we all have to die of something, you know, and like, that's seriously a response you get sometimes, I think. I think everyone's heard that at some stage. And there's that other one that, you know, I know what's good, I just don't have time to do it. You know, I'm really busy. And everyone appreciates people's busyness, and I'm sure this man is really busy. Just in terms of your... did anyone figure out his risk score? Anyway, it's 20%, okay? He says his absolute CV risk score is 20%. Just in your group, just have a bit of chat about what you would do for a person like this today if they were in your room, okay? And really about what you think success looks like from this consultation. Okay, so we'll just do that for about 5 minutes. So does anyone want to talk about what their table prioritised or what they thought was the thing to work on today? Yep.
I just put the details in the risk calculator and took out smoking, and his risk reduced by 10%.
Totally, yeah.
If you've got time to smoke, you can have time to quit to smoke.
Yeah, that's true. Okay, so that's 100% true. So this is, I think I've got mine slightly wrong, but yeah, almost halves it, okay, in the one that I did. And that's to drive home that it doesn't matter what everyone's risk is, stopping smoking is the greatest thing that happens for their health, okay? And, you know, like, and that's just thinking about cardiovascular disease, not even thinking about lung cancer, dementia risk, whole bunch of stuff, you know, it's an incredible thing. So smoking is always the priority. What anyone focus on anything else with this patient today? Yep. Yeah, that's it, isn't it? Yeah, you know, we all work in these time constraints, and so it is about finding out, exploring with him what he's interested in doing, okay, and what he thinks is achievable for him as well. Yeah, totally. We're talking about, what we need is time with this person. We need serial consults, isn't it? You know, this guy is unlikely to magically change his absolute cardiovascular, you know, his risk factors all in one hit. But if we have longer consults, we have multiple consults, then we have an opportunity to help work with him over time to affect change. So what did success look like for people in this consultation? Yeah.
And then open up the conversation of smoking cessation. We're here to help you when you are interested. If you are interested, perhaps book that follow-up appointment to at least knock off one thing, or try to engage the patient in a conversation about what thing do you think is manageable to help reduce your risk, and could we maybe have a chat about that another day when you've got more time, or keep it in the back of your mind for when you're ready. Otherwise you've lost that person out the door because they feel like they're out of it.
Totally, 100%. So I don't know if anyone disagrees with that approach, but that's very much the approach that I have, is that, one, you have to address their agenda, okay? So if they don't leave with their flu vax and their pertussis vaccine and can't see their grandchild, they're going to be pretty pissed off at you. And, you know, often that whole, we worry about not sending them out with, I worry sometimes, I used to. If I didn't send them out with something with the right thing, you know, then I haven't done the right thing by them. But if they're not even interested enough to the point to come back, then it's unlikely that they're going to take up the therapies that you started that day anyway. So it's really a bit of a, it's not, don't want to use the word test, but it's sort of like, if you're interested enough to come back, we're probably at a stage where you're ready to start making change. If they don't come back, then the next time we start this conversation again and trying to remotivate them for the need to change, getting back to that sort of stages, thinking about the stages of change and where they're up, and they're at the pre-contemplation phase. So just quickly, one of the good things with that CVD risk calculator is that you can do the comparisons. Okay, so just stopping smoking, he drops down to 12%. Having a really modest blood pressure and cholesterol drop, he can get down to 5%, and getting to sort of more strict blood pressure and cholesterol targets, he's down to 5%. So he's, at the moment, he's 1 in 5 chance of having a heart attack or stroke before he's 60, which is, that's pretty damn scary. And if he, he's got a grandkid coming as well. So it's one of those, having a child is a big motivator for change. And we see that with pregnant mums, they can make amazing changes. And I think the same applies for people when they're having grandchildren. These will be in the slides, but this is a model from Vicky around what's different in self-care for Aboriginal and Torres Strait Islander people. Just to bring out 2 main things. One is that she thinks, and I believe as well, it's really important that a person has someone to support them navigate their care. That doesn't necessarily need to be Aboriginal and Torres Strait Islander health worker practitioner. It can be a friend or a relative who's experienced cardiovascular disease, and she calls them peer navigators, and I think it's a really important tool that everyone has access to. And the other is about, the power dynamic between clinicians and patients is there at all times. It's extra pronounced if you come from a background where, your culture has been persecuted. So that being aware of that power relationship and trying to just have yarning and not pressure persons is particularly important. So, I'm going to wind up.
5 minutes left. We're going all right? We're okay? Excellent. So just to finish off with a few more supports and things that are happening in this space at the moment to leave you with. How many of you have heard of our Health Professionals Ambassadors program, or Nurse Ambassadors as it was in South Australia? A few hands. Excellent. So this is started in 2004. And it's a way for the Heart Foundation to connect with nurses and other health professionals to help spread our messages. And we also get to learn from you all, which is fantastic. So it's health professionals with an interest in cardiovascular health. So that's the main criteria basically, but it means that you become our ambassadors. You spread our messages, you help link people into our programs, etc. But you also do a workplace activity, and so you advocate for change through your own practice, and we support you through that. And also you get to attend workshops and increase your knowledge and those sorts of things. So we have Sabine, our coordinator in South Australia here. Give them a wave, Sabine. So any of our South Australian nurses who want to have a chat to Sabine, please do. It's a fantastic program. Heart Week. Does everyone know Heart Week's coming up? Yes? Good. If you don't, you do now. April 28 to May 4. So make sure you jump online to that web link and request your pack for your Heart Week. Now, Natalie was hot off the press, those resources that were printed on your to your table, that wasn't enough for everyone. These will be available for you to use for consumers and for health professionals. So things around heart health check and absolute risk. They're a fantastic resource that we will have available to you shortly online. And also on Tuesday the 30th of April, 7 to 8 p.m, an absolute CVD risk webinar, free, live and recorded. And there'll be can I say this at 4 p.m? Multidisciplinary team of experts who will talk to you about CVD risk assessment, etc. And last but not least, just a couple of little things to mention. There's a huge amount of resources on the Heart Foundation website under the For Professionals banner, so please go and have a look at the specific topics, etc. In the patient support program space, so this is for people after a heart event as well, just so you're aware, we are now working on piloting our newly developed My Heart, My Life program. So we will be getting more information out into the stratosphere around what that entails and what that will look like, but that's on the other side of patients having a heart event. And last but not least, if you haven't seen it already, APNA, in partnership with the Heart Foundation, have a fantastic online training module, Cardiovascular Disease Risk Assessment and Management, free online. I actually did it the other day. It's really a little great resource to refresh and look through. But also coming soon, assessment and management for Aboriginal health workers and practitioners, which Jason has had a hand in. And there's a sign-up sheet for that on the tables as well if you're interested in hearing more details about that when it comes out. So that is it. Please come and see us up at our exhibition booth. They go up this afternoon. Please see Kerry. Wave your hand, Kerry. Kerry's presenting tomorrow in the 1:30 session. She's from our Victorian office and she'll reinforce a lot of the messages that we've said today. So please go support her in her session. Remember to put your name down on those sign-up sheets to receive the slides and to get information about the Aboriginal Health Workers online course. And that is it. Thank you so very much for attending. I hope you enjoyed yourselves and enjoy the rest of the conference.